So we go on with our next example from Denmark, presented by Emily Wogeman Thompson. And I look very much forward to it because the Danish have been very active always in guideline development, and I'm very curious about the current state of the art and what the current developments are. So once the microphone has been installed, the floor is yours, Emily. Yep, very good. Does it work?
I don't know. It works. Yeah, I hear myself very loud and clear. So, just going to put this in my pocket. Yes, my name is Emily. I'm currently holding a position as a research therapist at the Hvidovre Hospital in Copenhagen, and I'm also a quality improvement advisor. Do I have my... but I used to be part of a quality development unit at the Danish Association of Physiotherapy. And we did quite a bit of work on the guidelines. So my short presentation will be about the Danish national multidisciplinary guidelines and how we tried to go from the full-length multidisciplinary guidelines to a short versions that's more relevant to the physiotherapists. And then just a brief introduction to one of the implementation projects that we did with the unit. So the Danish national guidelines, we had quite a lot of guidelines published in a quite short time. So we had 48 guidelines published in a 3-year period. The National Danish Health Association developed the guidelines, and we had more than half of these contained recommendations on either physical activity or physiotherapists. And actually, if we look to the physiotherapy representation in the working groups, we had 32 working groups which had physiotherapists working in the working group. So we thought that was quite exciting for us to be ahead, both on the methodology, but we were also very much aware that the physiotherapists who were working in the guidelines, they were all academic. So there was still a big gap from the ones doing or developing the recommendations to the clinical practice. The Health Association did not do any implementation activities. They did publish an implementation handbook, which was very heavy in writing and it was long, gave lots of great advice, but obviously no funding for implementation was given. And it did not give any recommendation on actual implementation activities. It was very theoretical. Now the focus with the guideline from the Health Association is in updating the existing guidelines, and they keep developing about 3 to 5 guidelines per year, and then they try to keep up some methodology work for the professional societies to base their work on. But they really want to push the development of the guideline back into the professional societies. And what has happened is it's mainly been the medical societies who's been picking up that work, and not really a lot have been done in allied health professions. Before we did any implementation, we did a barrier analysis within the physiotherapists who work in the private practice center. That was my main focus for the work. We have approximately 250 to 280 clinics, and they employ on a broad spectrum about 3,500 physios, not all of them working full-time in the private practice sector. So we asked them, what are the main barriers for using the clinical guidelines? And I'm sorry some of these slides are going to be in Danish, but I will explain. So the main barriers for working with the clinical guidelines or implementing them in the clinical practice was, of course, time. A lot of the physiotherapists might see up to somewhere from 20 to 50 different diagnoses per week in the remote area. So they need the guidelines to be there, but they also need them to be less complex and less time-consuming to read. So time, complexity, lack of knowledge of content of the guidelines, but also how to use them was a major barrier. And then quite to our surprise, a conflict with patient preferences was one of the highest scoring barriers in this survey that we did, where we were quite surprised that actually we sent it up to 3,000 physiotherapists and we had almost 500 responses. So we knew that there was some interest in the guideline work that we would be doing. Some of the comments were these. They're very heavy in academic writing and methodology. They're not applicable to practice. They don't add knowledge nor guide practice. So why do we need guidelines? Yeah, Danes say it as is. They don't sugarcoat anything. The physiotherapy and the multidisciplinary guidelines, we found that some of the recommendations were the adaptation to the physical therapy practice was really hard. It was easier to see for the physiotherapists in the hospital setting to see how they were filling this task in a very broad work with the patients. But when you're a physiotherapist in a private practice, you see the patient and you feel like you have the full responsibility for the patients. But sadly, they could not see what the responsibilities according to the guidelines was to them. They felt very distant to the recommendations in the guideline. So we started a project where the aim was to create a short version of the guideline. And instead of doing that as a multidisciplinary short version, we did a physiotherapy version of the short version of the guideline to make sure that they knew this is my responsibility, this is where I can see myself as a clinician in the full-length guideline. Then we planned different implementation activities that were to address the different perceived barriers. And we tried really hard to promote and tell them or educate them on how the different implementation activities might impact their everyday practice for them to choose the one that was most suited for what they actually needed. So just to give you an example on how we did the short versions, this is one of the guidelines. It's in Danish, in full length. This is about, I think it's about 80 pages, and then we have appendix that's coming up to more than 250 pages if you want to read it all. That's in Danish. And then we have the quick guide, which is published by the health authorities. That states all the different recommendations, but the problem was when the physiotherapists read this, they did not see themselves in it, and they did not see where is my task, what am I supposed to do with it. It has a lot of things about medication, surgery, but in there are some quite, at least from our perspective, some really relevant recommendations for the physiotherapists. So what we did was try to see, okay, let's look at the recommendations and only look at the recommendations where physical therapy or physical activity is present. So this is from the guideline on urinary incontinence, and we have the supervised pelvic floor muscle training, which is definitely an area we should work in. And we also have, where is it? Consider offering supervised weight loss problem. So one of the main things they said is, I don't know what this means. If I see a patient that explains problems with incontinence, yes, I do consider offering them supervised pelvic floor muscles, but what am I to do? How do I do it? So what we wanted to do was extract the fit factors, and also give them a bit more information. So the short versions that we wrote are 8 to 10 pages on the guideline, explains how the guidelines produced and developed, and then they have the recommendation, but then they also have key messages for the clinician. What's the most important thing for the physiotherapist to remember when they engage in these interventions? And then we have this, and this is not a proper translation. That's something I just did for you guys to make sure everything wasn't in Danish. But that was what we would do then. Take the recommendation that's relevant to the physiotherapy and put all these things in so they can open up the booklet, look at it and say, okay, at least I can do this. I have some of the booklets. They're in Danish or the short versions. You can have a look at them if you want to. This is for low back pain, did not translate that one, but just to show you that it's actually quite simple. And once we explained to them and went over the implementation activities, they could actually just pick up this short version, look at this and say, okay, now I know what's behind the consider phrasing of the recommendation. Multiple sclerosis as well. All the short versions are available in Danish, and if you have the English quick guides, I'm sure you can make some sense of it. We have now published 18 of the short versions. What's really important for us is keep it as simple as possible. We tried different types, different layouts, and they went with the simplest one. The clinicians forget all the graphics, forget all the stuff. I need to look it up and look at it, and that was one of my darlings that was killed. We had some very nice layouts, but they did not want them. They wanted as simple as possible, so that's what they got. Now, the way we develop them, in the beginning, I did all the extraction from the guideline, and if it was not set in the guideline, I went back to the literature that was included in the guideline, and I did all of these. Now what we do is we actually ask the physiotherapists who've been on the working group, as soon as the guideline is published, we ask them to extract the data. They get a questionnaire of what knowledge we need from the guideline, get them to extract it. It takes them roughly 10 hours to fill in these short versions for us, and they'll be ready to go to a peer review within a month with the Health Association. They approve all of our short versions, and then they're published on the website. So I think that's good that it's going fast anyway. What we did also is target these different implementation activities because the short version was one product that we needed to promote the guidelines. But what we did, and the data I'm going to show you is from the Copenhagen, the capital region of Copenhagen. That's the first part of the project, but we have done it across the country. We did education, focusing on the content of the recommendations. We did a network group targeting clinical level barriers to implementation, and we tried to use the system of profound knowledge and the Plan, Do, Study, Act approach. And then we offered to visit the clinics as implementation facilitators, focusing on both content but also on the more organizational barriers that were to implement the guidelines. The first workshops were the introduction to what is a guideline, introduction to the short versions. We had 119 physiotherapists from 43 clinics attending, and then they could sign up for whatever they felt that they needed to proceed in the implementation of the guidelines within their clinical practice. Quite a lot signed up for me coming to visit them. It was a nice setup. They felt they had could choose between 3 hours and a full day, depending on the size of the clinic and what they needed. The networking group, we had quite a few challenges getting them in there because it takes a lot of time if you're in a networking group. And then we had the education. Quite a few signed up, but a lot of people didn't show up. So what we learned from the education part, it did increase the knowledge of the guideline content, and it did raise awareness of the existence and an increase in interest of other guidelines. They expressed the need for further implementation support. Now I know what I need to implement, but how do I do it? If we look to the networking group, it was really hard to attract them to join the group. They felt that that was a massive responsibility. But one of the networking groups that really worked out successful were on a subgroup where they only see the patients in a home-based setting. And they really felt the need to see how does the guidelines live in the context where I'm in. And then lastly, the visits to the clinic. It worked really well from a strategic point of view, and what we saw was it provided them with the tools to go on with implementation of other guidelines on their own. Oh, sorry. We do not have any data on how they are actually, how are we doing, because we have no way, the way the thing is set up now to collect that. But one of the things we did track was activity on our webpage. And now we just published 8 of the short versions, and what we saw was actually in the first, after putting them on social media that they were out there now, the next 8, we saw that we had approximately 1,000 hits within the next 2 weeks following that. So that was unique hits from about 13,000 physiotherapists. So we know we're getting out there. We don't know whether they use them but we know they want to read them anyway, and we hope that's going to help with the implementation. Yes.
Thank you very much.
Thank you.
Thank you, Emily, for your presentation, talking about how to get all this evidence condensed into a summary of a few pages, simple but effective. Well, to some extent effective, you have to dig into that a bit further. But I think we realize that, I should say we do not realize that sufficiently, that it takes a lot of effort because it's easier to make a big guideline than to make a short one, because you have to select what information will you provide and what not. And that's always a big effort, but I think you made a good example of how it can be done. So thank you for that.
Thank you.
Questions from the audience? I'll walk to the back.
Thank you very much for your presentation. I just wanted to ask, when you did the clinic visits, because you were investigating the barriers for implementation, what was your experience for the private practitioners? What kind of barriers? Give us a couple of examples that they had to implement the short version of the guidelines.
I think what characterizes the private practices in Denmark is they don't see themselves as a unit. It's one physiotherapist working with this and one physiotherapist working with this. So you might have somebody who's really keen on working with guidelines and somebody who's just, I took these courses, I know what I'm doing, I'm a physiotherapist, I don't need the guideline. So I think one of the barriers was the diversity of the clinics, but bringing all of them together and having management level there as well, and accepting that they need to use small steps. So just printing out the short version, having them on the table, deciding on an implementation plan, where are they going to take us? And also some of the more conservative physiotherapists, asking them, well, how do you get to a point where, because we are obliged to use the guideline in Denmark, so they have to use them. How do we get you to go to that level where at least you can say, okay, fine, I read the recommendations, I understand what they mean, and for some of the clinics we made tick boxes. Okay, do we do this? Yes. And for some of them we really engaged in the group training with a group of patients, help them do interview with the patients. Do they feel like you are actually promoting physical activity, for example? So we did it on various levels. I don't know if that's answering your question.
Thank you. One more question and then we go on to the next presenter.
Just a quick one. Thank you, Emily. These were multidisciplinary guidelines, all right?
Yes.
So you had to work with other professionals?
Yes.
Okay. How was that?
I was in 3 of the working groups at the health associations. I think physiotherapy was well represented and they listened. I know working with the occupational therapists, they did not feel the same. They did not feel invited as we did. But I think when they did not do any implementation activities, what we said from the association was, well, we need to do something on our own then. And then we created the short versions and said, okay, this is what we're doing. We would like for you to approve so that the content is still, but this is from a physiotherapy perspective. But to use this guideline in practice, we need something else. And now we see the health authorities actually using our short versions to promote to the doctors and the nurses and the occupational therapies what they should be doing in terms of making the guidelines implementable. So I think at least the health authorities will listen. I don't know whether the doctors will, but they'll implement them their own way.
Okay, thank you very much.